Hi, everybody. My name is Tom Luby. I'm the CEO of Conavi Medical, and I'm very pleased to welcome you to this webinar featuring the hybrid IVUS OCT imaging. I'd like to introduce our presenters. Dr. Megha Prasad is an interventional cardiologist specializing in high-risk percutaneous coronary interventions at Columbia University Irving Medical Center, NewYork-Presbyterian Hospital. Dr. Prasad received her medical degree from the University of Southern California and her master's in clinical research and translational science from Mayo Clinic, Rochester. She received her internal medicine and cardiology training also at Mayo Clinic in Rochester, Minnesota, and interventional cardiology training at Columbia University Irving Medical Center in New York City. She also completed a year of advanced training in complex and high-risk percutaneous coronary interventions and mechanical circulatory support at Columbia University in New York. Dr. Prasad's academic interests include coronary physiology and imaging, especially in women. Our next presenter will be Dr. Khady. Dr. Fall is the head of imaging and physiology, adult interventional cardiology at Columbia University Irving Medical Center, New York-Presbyterian Hospital. Columbia University Medical Center is one of the few hospitals with a dedicated imaging physiology team, and she is the head of the team that uses imaging and physiology in more than 80% of the cases. Also, she regularly trains fellows from other New York City hospitals, as well as medical industry staff. Dr. Fall is involved in several cardiology publications and research studies. Dr. Fall has a master's in public health and is a foreign-trained doctor from Senegal with over 17 years of cardiology imaging experience. And finally, we have Dr. Courtney, who is an interventional cardiologist at Sunnybrook Hospital in Toronto, as well as a scientist from the Schulich Heart Research Program and assistant professor in the Department of Medicine at the University of Toronto. Dr. Courtney is a co-founder of Conavi Medical and serves as our chief medical officer. Brian's clinical activities are primarily focused on complex coronary interventions as well as acute cardiac care. His research focus includes imaging and therapeutic catheters for minimally invasive cardiovascular procedures, as well as the application of AI and machine learning to image-guided therapeutics. Dr. Courtney has engineering degrees from the University of Waterloo and Stanford and received his medical degree at Stanford. He completed his residencies and interventional cardiology training at the University of Toronto. And so without further ado, I'd like to turn it over to our first presenter. We'll be recording this session, we'll be posting it online, and you can also provide some questions in the chat and we'll capture those and hopefully answer them by the end of the session. Thank you.
Thank you so much for that kind introduction, and thank you so much for having me here today. I have to tell you, of all the toys I get to use in the cath lab, this is one of my favorites. As Khady will tell you, we're always pulling it when we can. So I'll be talking a little bit about integrated imaging, like you know, IVUS and OCT, and going through a couple of my favorite cases, and really some cases just from last week. So a routine week in our cath lab. My goal today is really for you to understand the clinical uses for hybrid intravascular imaging so that you can be a better imager, so that your patients can benefit from the technology that is now out there, and so that you can overall deliver better care when you're in the lab. So some key considerations are first that it's important to understand that this Conavi device is essentially designed to integrate both intravascular ultrasound and optical coherence tomography imaging into a single platform for acquiring clinical images with both modalities simultaneously. And it's important to understand that simultaneously you can get an OCT frame and an IVUS frame from the exact same position, and that can be clinically very relevant. The IVUS and OCT beams are inherently co-aligned, allowing for dual modality visualization of the same vessel cross-section. And this combined imaging allows us to provide the penetration and blood field compatibility of IVUS with the resolution and lumen detail of OCT when we're taking care of our patients. We know that IVUS has several advantages, and I, before Conavi, used to be more of an IVUS user because I take care of a lot of patients with impaired renal function and need to reduce contrast, I'm interested in it being something that I've used more, and so I'm just more comfortable with IVUS. The depth of penetration also is an important consideration, and so with IVUS, the depth of penetration allows better overview of the complete vessel. For example, it's easier to distinguish between positive and negative remodeling or deep hematoma. It's also easier to get an accurate measurement of the vessel, which is important to me. OCT can sometimes be more difficult, especially if your EEL is not able to be visualized. But the cases that I pull OCT for, I find myself falling in love with OCT as well. The resolution is beautiful. It allows me to visualize detailed structures, such as small dissections. It allows me to distinguish multiple stent layers and more appropriately treat patients with in-stent restenosis. And allows me better visualization of calcium thickness, so I understand how I'm going to modify calcium in certain patients. The thin cap fiber atheroma can only be measured with OCT due to superior resolution. And in any acute coronary syndrome, you can visualize thrombus, red or white, better, and plaque rupture at times better with OCT as well. And then Conavi came along, which really took the benefits of IVUS and the benefits of OCT and put it in one imaging device. So when I'm sitting there trying to decide, do I want the IVUS or do I want the OCT, Conavi has allowed me to have the cake and eat it too. And so now when I'm able to pull the Conavi device, I'm not having to compromise. I can get penetration depth while I can visualize calcium, while I can understand plaque rupture, thrombus, and edge dissection. So you can see here, and I'll leave this slide for you to review later, there's advantages to IVUS, advantages to OCT, and this system capitalizes on both. Cases I consider Conavi for are really all the cases that I do. But I tend to do a lot of calcified lesions, complex disease there, osteo lesions, low contrast PCI with patients that have creatinines of 3, 4, 5, and 6, CTO PCI, left main bifurcations, underexpanded stents where I may want to get more visualization of the stents because the stents have restenosed, acute coronary syndrome or graft PCI. So basically all cases are appropriate for Conavi. This is a diagram from the company that really nicely goes over what it is that we're able to do with this technology. So when I insert this catheter, I know that I'm able to get IVUS and OCT at the same time. There's an ultrasound transducer, as you can see here, and simultaneously there's this IVUS beam that you're used to from your IVUS catheters and your OCT beam, and simultaneously this is assessing the vessel at each point, and then it's pulling back. And for the interest of time, I'm not going to spend a lot of time on this video, but I'll leave this for you to go over on the website. I will point out the images here. As you pull back, you'll get IVUS images and OCT images, and we'll go through that in more detail as well. So let's go ahead and go into the first case. This is a 72-year-old patient that came in with an NSTEMI, a GFR of 15, and a previous anterior ischemia on their SPECT 2 weeks prior to presentation, and anterior wall motion abnormalities on their echo. Given their GFR of 15, we were trying to minimize dye, so we took one apicaudal picture and one minimal contrast shot of the right coronary artery. And then we went ahead and based on this image here, we knew that there was disease, so we suspected that we were going to need to at least interrogate the LAD, and we could see that there seemed to be at least moderate disease in the LAD on the caudal projection. So we went ahead and took a guide and wired this with minimal contrast, wired the diag, wired the LAD, and then went ahead and took a picture while we ran our Conavi. So this is one of the ways that you can minimize dye when you're doing the OCT part of Conavi, because I know that I can then toggle in between OCT and IVUS as I need. So here, this was my initial image, and you can see on the left is the IVUS and on the right is the OCT. And when I'm getting these images, Khady and I's eyes are going back and forth between the IVUS and the OCT to try and pick up on different pieces of information that we've trained our mind to think about in each of the scenarios. And then we can pause and go back and really look. And some things I want to point out here is, you can see that there's a calcium nodule that's more easily visualized on the OCT, but is visualized on the IVUS as well. And when you see both of these together side by side, especially as you train yourself to be an expert in intravascular imaging, it's important to be able to understand that you'll more likely pick up the structure on one if you see it in sort of two different projections, so to speak, but in this case, two different technologies. OCT is wonderful for seeing branches. So I see that there's a septal here. Again, I see this calcium nodule, and I'm able to get assessments both from IVUS and from OCT. And Khady and I consult and say, okay, we don't really think we need any sort of aggressive atherectomy or calcium modification here. I know I need to stent across a diagonal, and I can use the jog mode to decide exactly how many millimeters proximal and how many millimeters distal I want to stent and really get a precise PCI. So here you can see the diag is more easily visualized on the OCT, but it is present on the IVUS. And to be honest, when I was learning imaging, I may have missed that this was a diag initially, but it's obvious here. So as you train yourself in this system, your IVUS skills will get better as your OCT skills will. We went ahead and placed the drug-eluting stent in the mid-LED, distal to the diag, based on what we were able to gather from the OCT and the IVUS. And again, for the interest of time, I'll go through this relatively briefly, but I'm looking for, is my stent expanded? Do I have a distal edge dissection? Do I have a proximal edge dissection? Is my stent opposed? And on my final LED images, you can see here that, the diag looks like it's open. I'm looking at my distal stent edge. And this seems to be okay, except here in a slightly different, one more frame forward, you can see that there is a small distal edge dissection, and we went back and forth and measured it and knew that there was nothing further that needed to be done because it was so small. But notice we're not able to visualize that on the IVUS. And so some people will argue, well, if it's not clinically significant, you don't need to see it. But I would argue when I'm treating a patient, I want all of the information, and I want to know if there's even the smallest of dissections, which I can see here, but then based on what I'm seeing on IVUS, I can then decide whether or not I need to treat or not. And here you can see that the LED stent is well expanded. And again, we see a small proximal edge dissection on OCT that we don't see on IVUS. And this is just another great example of how this technology gives me more information and allows me to act. So we did not treat the proximal or the distal edge dissection in this. And we saw that the calcium nodule was not having any, did not cause any issues. So this was our final angiogram. And I'll move on to the next case. This is a 52-year-old male, multiple risk factors, including diabetes, presented with a syncopal episode during dialysis with chest pain. The LED was fairly insignificant. There was a 70% osteoproximal lesion, but otherwise mild non-obstructive disease in the left coronary artery. And then the right coronary artery appeared to be honest, moderate disease. This isn't something that I would have been terribly concerned about, except for the fact that we took multiple projections and the patient's presentation. So here we went ahead and took a JR4 guide with side holes, wired the vessel, and used our Conavi system to image. And what we're looking for here is three things. So this is something that I'm worried about. Is this going to be an osteal lesion? Is this calcified? How long of a stent do I need? And where exactly am I going to land my stent? And so based on our pre-imaging, again, I'm looking at the IVUS and the OCT simultaneously, and we were able to get beautiful images on both sides. And as we come closer, to the guide catheter, you'll see that there's an area where there's a lesion, and I'll go through this in more depth here to make this a little bit clearer. So you can see here that there's attenuated plaque. In this view, you can see here that the EEL is very easy to visualize, and so we're able to get our diameter so that we can then decide what stent we will need and what balloon we'll need. And it's important to see here that in the proximal part of the vessel, there is a ruptured plaque, so that explains to me the patient's acute presentation. So there's a flap here, and so this is consistent with the ruptured flap and consistent with an acute coronary syndrome. You can see here that IVUS is used to measure the plaque burden, which again appears significant. Here we went ahead and pre-dilated with a 2.512 balloon, and then we placed one stent at 3.518 and then another stent more proximal. And we use the Conavi, in this case, the Conavi's jog mode, to mark our ostium. And the second stent, this 412 millimeter stent, was placed coming just up to the ostium, and we were able to confirm that on our post-Conavi run. And so this was important because when you're trying to place stents exactly, that's sometimes difficult to do with just OCT technology. But the fact that we have the jog mode and we're able to do this with IVUS, again, it's another area where having both technologies was important in this case, because the OCT allowed me to understand that this was a plaque rupture and visualize something that I wasn't able to visualize on the IVUS. But then technically, when I'm placing the stent, I was able to mark the ostium in a way that would have been more difficult if I just was using OCT. And so this really takes advantage of both technologies like we've been discussing. You can see here the calcium nodule again, and we look at the proximal stent edge and the distal stent edge, and you can see that there's some tissue prolapse. And the other thing you can see here is that we have overlap stents that are visualized on OCT, but not visualized as easily on IVUS. And so you can see if this was a pre-image, it sometimes may be hard to tell if that's stent or if that's calcium, but you may need to use IVUS for something else in the case. So again, you're able to toggle back and forth between these. So I want to go through briefly why I like Conavi. For me, I feel like every time I walk into the lab, it empowers me to get more information. It takes less time, and it really improves the quality of my PCI. It lets me take the time to really make decisions, and it doesn't make me feel pressured because I don't have information that I would like to have. The jog mode is excellent. It allows for co-registration. It allows for you to precisely place your stent. It's also important to understand that you don't need to decide between IVUS and OCT, and you can do that on a run-by-run basis. So on a certain run, you may want the IVUS. On another run, you may want the OCT. On another run, you may want both, and you can do that on a run-by-run basis. So you're not really using much dye if you don't need to. You can view the same structure or imaging on both sides. And so if you're not sure what something is on one area, you can look on the other side and then get an idea. Oh, well, that's probably a calcium nodule. Oh, wow, that really is a dissection. And that's very helpful as well. And I think personally and selfishly, the other reason I like this technology so much is because it allows me to improve my imaging skills on a daily basis, because I'm getting better at OCT, I'm getting better at IVUS, and I'm getting better at understanding these two technologies together. And that's important. So some key take-home points are: first, integrated IVUS and OCT have many important clinical uses, and it can help you and your patient because you're able to deliver the best of IVUS and the best of OCT in the same patient. It's important to understand that the image quality is continuing to improve with each iteration. And so in just the last year, it's amazing how much better the technology continues to get. And if you, especially, if you're junior faculty and you're starting to get into intravascular imaging, it's one of these technologies that if you jump on this bandwagon, you're going to be a better imager by the end of it. And you're going to be able to participate in each round of improvement in the technology. It's also important to consider the use of integrated IVUS and OCT, especially in patients with ACS, ultra-low contrast PCI, and in-stent restenosis, where these patients have complex lesions, poor outcomes afterwards, and can really benefit from imaging with both IVUS and OCT. And then, like I mentioned, selfishly, as you train yourself for the future, hybrid imaging is going to make you better at OCT and better at IVUS. And if you adopt this sort of technology early and participate in the development of such novel systems, it's really going to help shape the future of intravascular imaging and your career as an intravascular imager and an operator. Thank you.
Dr. Prasad, thank you very much for that presentation. I know we'll have some Q&A at the end, but maybe we can just pause right now to see if there's anything that folks would like to ask directly after her presentation. Okay, please use the chat as you're thinking about it, and we can collect those and have a little discussion at the end as well. But I'd like to reintroduce Dr. Khady Fall. Dr. Fall, please take it away.
Thank you. Let me share my screen. Good evening, everybody. Let me just give me 1 second. Yes, sorry. Okay, like Megha just said, since we have been using the Conavi before that, how many times did we use a system? We opened 2 catheters because what happened is one system wasn't able to answer all the questions. So how convenient is it to open one catheter and have both solutions right away? So since we know Conavi, Megha and I have been using it a lot, both of us. I am going to talk about two cases also. The first case is an 89-year-old male with peripheral arterial disease, AFib, and a quadruple bypass. He presented with chronic coronary syndrome, class 3 angina with abnormal stress tests. His past medical history was in February of this year. The patient had a CABG, a Lima to LAD, a SVG to D1, and SVG to PDA, and sequential to LPL. Then what happened? 3 months later, after the CABG, that SVG to the RPDA, they had to do a PCI. There was a lesion. Just 3 months later, they put a 3/5/20 stent. After that, in 2000, the RCA had a PCI twice, in 2001 and in 2004. So there was multiple stent. Because of the multiple stent, not only we have multiple stent, multiple layers, unfortunately, there were recurrent ISR. The last time the patient had a PCI on the RCA was in August of last year, where they needed to do a brachytherapy because of the multiple layer of stent. The CIRC and the OM had a PCI in October of last year. The patient presented with prior TIA, AFib. The social history is unremarkable, and the mother had cancer. These are the medication, the labs. For the EF by echo, the EF is normal. And when they did a nuclear stress test, it shows that there was large to moderate reversible anterolateral and inferior lateral and inferior perfusion. With a normal EF, they confirmed the EF also with the stress test. So let's go back to May, when the patient after the CABG, 3 months after, had, this is the angiogram, and the RCA. The patient presented a lesion just 3 months after the CABG. If you see on the angiogram, you can see a clip at the lesion, and the surgical clip was the one responsible for inflammation process at the SVC. And because of that mechanical process, they had to put a stent at 3/5/20. And this is the angiography. They balloon, and then they put the stent, and the final in May, this was the final angiography. So the SVG to the PDA was completely open. Then 4 months later, the patient, because of the class 3 type of angina, came back to the cath lab, and we did the angiography. Let's start with the left side. As you can see, the CIRC was occluded. Another image of the CIRC, an ISR again of the CIRC. And here, the proximal LAD, you see the slight lesion just proximal to the trifurcation. And now let's look at the Lima to the LAD. On the other hand, the Lima to the LAD is completely patent. So this is the angiography of the RCA, and we have a CTO of the RCA. Because of the territory on the stress test, when we did the SVG, before that, sorry, this is the SVG to D1, it looks completely patent. And then the angiography of the SVG to the PDA showed at the exact location of that previous lesion, another lesion. There is an ISR of the SVG, the proximal SVG to the PDA. So what did we do? The SVG was engaged with a multi-purpose guide, and they wire it with the Xi'an blue, and then we decided to IVUS it. And this is the IVUS OCT, I mean. So I'll go through very slowly, then I'll show every single. So it shows that it's a big vessel is about a 3A vessel. And on the other hand, we're still distal to the stent, but you can see that there was a lesion distal to the stent. There's already an MLA that is small, then we are in the stent. So we can see the mechanism of this ISR. We can say, number one, the stent was well expanded. As you're going more proximal at this location, you see that there is intima hyperplasia, severe intima hyperplasia, but the stent still looks well expanded. So we're going more proximal, and as we're going more proximal, you see that part of the stent struts are disappearing here. And I'll go through every single frame after. And then we see something protruding inside the stent. You can see it a little bit by IVUS, but here OCT was very clear. And we still can persist from the distal to the proximal that the stent is very well expanded. And we're reaching the proximal part of the stent, and you see from 12 o'clock to 4 o'clock a structure that is protruding. And we're proximal to the stent, and proximal to the stent, you see that the lumen area is small. As you go more proximal, the lumen area gets bigger. Now let's go step by step. Let me just do the complete run so you can see. So the mechanism of ISR is definitely not underexpanded. The stent was well expanded. You have ISR, and you have a lesion distal to the stent and proximal to the stent. Now let's look one by one. So in this frame, distal to the stent, that you see the stent size is a 3/8 stent. And then on another frame, you see the vessel size is 3/8, the stent size is 3/2. This is a proof that the stent is well expanded. This was the ISR, and the lumen at the ISR, the MLA at the ISR, the minimum lumen area is 1.1. As we're going more proximal in the stent, if you remember, I talked about an area that you don't see the stent strut. And we talked, my first thought was a stent fracture, a partial stent fracture. You see it as well on IVUS, and you see it on OCT. The fact that you're able to see the stent strut from 9 a.m. to 2 p.m., and then the rest disappears, my first thought was a stent fracture. Then when we went more proximal, it continued, but I realized that there was what we call by OCT attenuation. Every time that you have attenuation, it means it's a hyper intense structure, which is a lipidic pool. When the light goes through the lipidic pool, what happens is some of the signal is dropped, so you cannot see what's behind it. This is why we're not seeing the stent strut. We can guess a little bit here that there was something going on. So the fact that we combine OCT, and IVUS, one was able to confirm what was going on, what was not clear on the other one. If we didn't use the Conavi, I could have, I'm pretty sure that that day we would have opened 2 catheters from 2 different machines, one IVUS, one OCT. The fact that we have the images side by side were able to convince me that it was not a stent fracture, but on the other hand, there was a lipidic pool because of this attenuation, the shadow. This was the reason why we were not seeing the stent strut. And as we're going more proximal, we still see something, but here it was very clear. You can see by IVUS, there is an irregular structure protruding in the lumen. Usually when you see something irregular protruding in the lumen, I think about 2 things. It's either a thrombus or a calcium nodule. But because I have the OCT on the other side and you see a lot of attenuation, I can confirm there is a high chance that it's a red thrombus. If it was a white thrombus, there wouldn't be this much attenuation. So this shows you the fact that you have OCT, 2 imaging side by side. Whenever one of them cannot answer the question, the other one can clarify. So after knowing that not only distal to the stent, there was a lesion within the stent, there was a thrombus probably and ISR, and proximal to the stent, there was a lesion. We decided to first of all, to dilate with a 3015 at a maximum of 20 atmosphere, as you can see here. Then we decided to IVUS again to put a stent, a 3.5 38 stent. And this is after putting the stent in. Let's go back in. Let's show. So if you look exactly at 10 o'clock here, that was a big dissection. You see it clearly by OCT, a little bit more challenging by IVUS. So the good thing about OCT, because the resolution is 10 times the resolution of IVUS, you can detect any structures. But the fact that this, the dissection flap was, let's say, medium size, it was less than 60 degrees. But when we were measuring the length of the dissection, it was about 6 millimeters. That was the reason why we decided to put another stent. So as we're going more proximal, it was distal, like really distal, and then you see the stent, the distal stent edge, and the new stent that we put in was well expanded, and here you can see the overlap with the previous stent, and you can see it better by OCT than by IVUS. And as we're going, this is the complete run. Overall, all the stent is well expanded, and we covered also the lesion that was proximal to the previous stent. Now let's go, if you want to look at it, let's go frame by frame. Again, this was the distal dissection. This is the distal stent strut. And as you're going, overlap, you can sometimes see it by IVUS, but it's challenging if you have calcium behind it, because the appearance of stent strut is the same, is echogenic, just like calcium. But when you're dealing with OCT, you can clearly see how many stent strut. How many times did we did cases, all we know just by using IVUS, it seems like there are multiple layers of stent, but we are not sure. And in that case, again, we were ready to open another catheter. But here, the fact that you're using Conavi, you're just using one catheter that gives you both information. And here was the MSA 7.3. Although the 7.3 was a good MSA, let's continue. Because of the precision of the high resolution of OCT, you're able to see tissue prolapse that appears clearly here, but more challenging by IVUS. So, but tissue prolapse, what you need to know about tissue prolapse is it doesn't interfere with the, as long as the tissue doesn't interfere with the lumen area, the minimum lumen area, you don't need to do anything. It doesn't have an impact on the outcome of the case. So just to precise you can see here the tissue prolapse by OCT, and you can like just subtle, you see a little bit here by IVUS. Okay, as we're going more proximal, again, the proximal stent edge. So because the length of the dissection was more than 5 millimeters, we decided to add another stent. And this time it was a 3/5/16 millimeter stent at 24 atmosphere. And this was after putting the stent, and we decided to do the final IVUS. So this time by doing the final IVUS, just to make sure there is no distal dissection, the Conavi catheter went really distal. And to my surprise, but a very good surprise, this is what we saw, and I wanted to share it. So we went extremely distal, where you can see completely like the vessel is completely normal by OCT as well by IVUS. You see a little bit blood swirling here, and this is the catheter at the center. As we were very distal, and we're going more proximal where the vessel is normal, to our surprise, you will see something appear right here. So the first reaction was, is this another dissection? Then when we looked at it more in detail, it was a venous valve. And a lot of people don't have this chance of seeing every time a venous valve, and including me, I saw it just once. And the only time I saw it, it was not that clear, not as clear as this one. So this was the run. And I just wanted to show you the venous valve again. And there it is. But let's go frame by frame. So this is distal to the stent, and at the venous valve, you have this indentation at this location and at this location. So that's the first thing that made me doubt that it was a dissection. And when you go frame by frame, then you see one part of the valve and the other frame, the other part of the valve. If you look at the venous valve, like in a longitudinal view, you can see the two valves here. And again, I've been doing this for years, but this is the first time I see a very clear venous valve. Then we go distal to the stent edge. It looks great. And here again, you can see that the stent is well expanded. And also the MLA is 7.4. We see the overlap with the previous stent that was put in May of this year. And just the expansion is very good. And this was the proximal stent edge. And here's the final angiography. And that was the SVG to the PDA. Then at the end, I'll ask the question. Anyway, let's jump to the case 2. This time it's a 65-year-old man with a past medical history of coronary artery disease. So 7 years ago, this patient had a mid-LAD PCI with 2 stents, 2533 and a 3028. He has risk factor, tobacco use, hypertension, dyslipidemia, and diabetes. He presented with shortness of breath and also with minimal to moderate exertion with the New York Heart Association class 3 and the typical angina with moderate exertion class 2. The nuclear showed that there was inferior and septal wall, moderate to small to moderate size area of inferior and septal wall disease. So this is the angiogram. As you can see, the mid part of the RCA is disease on both, and the disease looks very tight. Then we decided to do the left side, and this is what we're seeing on the left side. The circ looks fine, but the LAD looks borderline. Let's go to the next one. Again, mid-LAD disease. And it looks like an intermediate mid-LAD disease. So this is when we decided to do physiology. We started just to make sure if the LAD required like to have a PCI right away, or we can defer it. So they did RFR, and the result was borderline 0.90 to 0.91. Since it was borderline, although it's negative, but it was borderline, and we know that the LAD, usually when the bigger the territory, unfortunately, there is a 20% risk of having a mismatch between the FFR and the resting indices. So we decided to confirm with the FFR, and the FFR came back also negative, but borderline. So we decided to proceed with the RCA. So the first thing we did, we tried to IVUS directly the RCA, but it couldn't cross because it was too tight. This is when the decision was made to balloon with a 2.515, and then we IVUS after that. And this is the run. So you can see distally, the RCA looks like a big vessel, and is you see on the OCT side, you see the media, the 3 layers. The darkest one, which is the hyper intense one, that's the media. The most inner one, close to the lumen, that's the intima, and this is the adventitia. So you have a 360 of a normal vessel. So as we're going more proximal, since this was balloon, we're expecting to see any type of dissection. But let's see, we're going more proximal, and then you see the marginal coming in. And then here, you see a mixture of calcium and fibrous tissue. and you can see it as well here. If you look at the IVUS, the calcium that you see, this is what we call deep calcium. Why do we call it deep calcium? Because it's embedded within the plaque. On OCT, you can see it clearly. If we were to measure the thickness of calcium by OCT, you can see it. On IVUS, since sound wave, when it hits any calcific tissue, the signal is dropped. You can see calcium, but you will not have an idea of how thick it is. Again, one of the advantages of having this catheter that combines both imaging. So you can see all these dissection, the big dissection that is from 6 o'clock and goes all around to 9 o'clock. But as you're going, because it was balloon, so these dissections were to be expected. Now let's look at frame by frame what we did. So this was our distal reference. As we're coming, like I just said previously, the deep calcium that you see here, and you see this dissection, but this is the fact that you're able to see on both sides. This is what we call an intimal dissection, because the media, the continuation of the media is still in. It's a dissection within the plaque. So this is what we call an intimal dissection. You see it as well with the OCT and with the IVUS. Now, as we're going more proximal, now we've seen another dissection, a more severe dissection. This is a media dissection because it's going within the media, and OCT will show you exactly how deep the dissection is. It separated the media. The dissection flap is more than 60 angle degrees. In case you're not sure how to measure the dissection flap, once you see the lumen of the vessel, you divide by a quadrant of 4. When it occupies more than one quadrant, usually it's a big dissection. But IVUS will show us something that OCT is not showing us, is how you see part of the hematoma here, but you don't see how significant the hematoma is almost around the complete vessel. Why? Because the depth of penetration of IVUS is more significant than the depth penetration of OCT. With OCT is 1 or 2 millimeter, with IVUS is about 10 millimeters. Again, let's talk about the dissection. So this is the dissection flap. You have an idea there is attenuation here, which is a hematoma, but this clearly shows you with the IVUS, you can see how deep the hematoma can go, which that's the advantage that IVUS has compared to OCT. And here you can see a little bit some calcium here and here. But OCT, IVUS can show you calcium fracture, but when the calcium fracture is very like subtle, you can see it more with OCT. So by comparing the two images, you can see the fracture here by OCT. You're able to see it slightly by IVUS. So again, another fracture here, another fracture here. Because we were able to fracture the calcium, so we know that the probability of expanding the stent that needs to be put in, the more you fracture the calcium, the better the expansion of the stent. Again, OCT is able to see calcium. Megha talked about it earlier. And the fact that you can see calcium, how do you recognize calcium by OCT, is any structure that is well-defined borders, that's a calcium. Again, by IVUS, you can see calcium, but you're not able to measure the thickness. So these are the different locations of the calcium fracture. Now, having the two technology side by side, IVUS and OCT, this will be one of my questions to everybody that can answer this. Because we have a specific calcium score by IVUS. And just as a reminder, the calcium score is just was published last year in 2021. If you see the calcium by angiography and the maximum, then you go to IVUS and you see a maximum calcium arc that is more than 270 degrees, you can start you can start counting the score. Every element should be considered as 1. So you have 270 degrees of calcium arc. And if the length of the calcium is more than 5 millimeter, that's 1 point. Then if you add in another location in the same vessel, 360 degrees of the calcium arc, you have another one score. If you see even just one calcium nodule, that's another score. And if the vessel is less than 3.5, that's another score. So by IVUS, if you get at least two score, 2 out of 4, you can think about arterectomy. Of course, if you get 3 or 4, you can think about arterectomy. And this shows you that the more you get the score, the higher the score, the better the result with arterectomy for the stent expansion. On the other hand, you have the calcium score with OCT. It's the rule of 5. So you talk about the arc. If the arc is less than 90 degrees, is 0 point. If it's between 90 to 180 is 1 point, and greater than 180 is 2 point. Now the calcium thickness, because OCT, like I said, can measure the thickness. If it's less than 0.5 is 0 point. If it's greater than 0.5 is 1 point. The calcium length, more than 5 millimeter, you measure it always in the longitudinal section. And then if it's less than 5 millimeter is 0. If it's more than 5 millimeter is 1. So on OCT, to be able to do arterectomy, they recommend to have at least a calcium score of 3 and 4. By IVUS, if you have a calcium score of 2, you can do arterectomy. So one of the questions I will ask after the audience is, if you have a system that shows you OCT and IVUS, which calcium score can you rely on? So anyway, what happened here after ballooning it, they decided to put a 3.5 33 millimeter stent, and then they post-dill it with a 3.5 15 NC. And this is what we're getting. And this is the final imaging. So we're distal to the vessel, and this is where the vessel is completely normal. And that was the branch, which is the marginal. So as you're coming proximal, there is no distal edge dissection. The stent is very well expanded. And we're going more proximal. Let's do the run completely. And you see the images side by side, very clear, very beautiful. And no distal edge dissection. Perfect, and no proximal edge dissection. So after that, if we go frame by frame, again, you're able to see tissue protrusion that doesn't interfere with the lumen area, so we don't need to do anything. You see it by OCT as well by IVUS. You get a lumen area that is big enough. And again, tissue protrusion, and you see the branch, you're able to compare both of them and the proximal edge of the stent. And this is the final angiogram, and the RCA is completely open and patent. So these were the cases. Thank you for listening, and let me know if you have any question. And about the calcium score, I just want to know the feedback of everybody that has an idea.
Dr. Fall, thank you very much for this presentation. I know Julie has collected a couple of questions, but I'd like to put one of our participants on the spot to prime them to maybe come up with an answer to your question, Dr. Fall. So Dr. Barantis, if you're still with us, maybe you would like to take a crack at that. After Julie asks one question, we'll get back to you so you can have some time to prepare.
Okay.
Yeah, sure. Sure, Julie, go ahead.
Okay, thanks, Dr. Barantis. Yeah, so one of the questions we had, so if you had to choose one kind of lesion in which hybrid imaging has been most helpful to you so far, do you have, what would it be, I guess, Dr. Fall and Dr. Prasad, maybe you as well, if you guys have different ones?
I was trained with IVUS before being trained by OCT. So I was way more comfortable with IVUS. And then after a few years, I started doing more OCT. But like I said, if I have to choose one, it depends on exactly what I'm looking for. If it's something, for example, multiple layer of stent, what type of thrombus, I will take OCT. But if I'm looking for like overall, just the distal reference, proximal reference, just the regular case that you do every day, I prefer to take IVUS. So it depends on what I'm looking for.
Yeah, I think that's a great question. So for me, if I had to choose, so, you know I sort of cheated and told you that I want to use Conavi in all of my cases, but if I were told I can only use it for one indication, for me, it would be my highest risk patients where I need the most information. And so those would be low patients where I'm trying to minimize dye, but maximize the amount of information I need. So in-stent restenosis would be probably the biggest one, because I can benefit from the OCT, but then and understand the mechanism of stent failure, but finish my case with IVUS without using extra dye. And any sort of acute coronary syndrome in the setting of previous stents to, like Khady said, better understand what the mechanism of the acute coronary syndrome is, where the acute plaque rupture is, learn that by OCT, and then finish the case by IVUS if I'm trying to minimize dye, because the majority of my patients, I'm trying to minimize dye.
Thank you. Brian, what do you think? You haven't presented yet, but you want to weigh in on this question?
I mean, I think ISR is a great one because of the reasons that Dr. Fall and Dr. Prasad mentioned. And similarly, we haven't done a lot of research yet with this in thrombotic ACS cases. We've done a few, but we haven't done a big study in that area yet. And I think that that's an area that'll be very interesting, because it's hard to identify thrombus sometimes on IVUS. The contrast is not always great. And the OCT gives a huge amount of detail when you do see something, but the thrombus gets in the way of seeing past the surface of the thrombus. And it's very easy to undersize in an ACS, especially, like a large RCA and a catetic vessel. So, having the both modalities in that circumstance, I think could be quite helpful. And I'm excited to do some investigations in that area in particular going forward.
And Brian, we'll get you going with your presentation here soon. And Christos, to put the spot on you here, do you want to take a crack at Dr. Fall's question?
Yeah. First of all, I would like to congratulate the speakers. That's a fantastic webinar. Such an educational cases and very, very nice illustration of the value of having both IVUS and OCT in guiding therapy. Now, the question was related to the calcium score, isn't it? What was the one to be used? Is that correct?
Exactly, yes.
I mean, from what I remember, there were much more cases that has been used in the IVUS study compared to the study that was used in OCT. In OCT was only a few hundred cases, while in the IVUS study there was a much larger number of patients. So in terms of the numbers, you may feel much more confident by having the IVUS criteria. Overall, it's difficult to argue in favor of one or another. What you have done exactly was very helpful to see whether you have cracked the calcium in multiple places. After pre-dilation, you have seen that was a decent dissection, and that gives you confidence that deploying another stent will give you a good results. I believe that was a very appropriate strategy, and this course, of course, are to guide us on how to proceed pre-cutaneous coronary intervention, but also we need to see vessel response and then make a decision.
Okay, thank you.
Thank you, Dr. Barantis. And boy, it's really late where you are right now, so thanks for weighing in.
No, it's a pleasure. I'm really enjoying it, and congratulations one more time for organizing this fantastic talks. I'm learning a lot.
Great, thank you. All right, without further ado, I'd like to turn the attention over to Brian. You've got a couple cases to talk about as well.
Yeah, thanks. I've got some fairly brief illustrative cases here. This is a 60-year-old woman who presented to our hospital at Sunnybrook who had chest pain, ECG changes, and positive cardiac enzymes, all consistent with the non-ST elevation myocardial infarction that was referred for coronary angiography. Unfortunately, she also had a bleeding history, and the cause of the bleeding had not yet been fully resolved. So we went into this case knowing that we would want to get some diagnostic information, but certainly had some trepidation about what we might have to do if we were to commit her to dual antiplatelet therapy. And I consented her for the use of the Novasight system, as I do in all of my patients, just because of my relationship with the company. We used IVUS and OCT in order to look at this LAD lesion. The RCA and the circ were unremarkable, but we had this intermediate grade lesion here in the mid-LAD after trifurcation between a diagonal and septal branch that we wanted to assess further and see if there was a lesion that looked more high risk. And I'll just run you through the video. You've got the OCT on the right and the IVUS on the left. And what I was really focusing on when I was going through this pullback was whether or not, first of all, using the IVUS to know that I was at an area of the vessel that was relatively normal distally before starting the pullback and exposing the patient to contrast. And then performing the pullback and looking carefully on the OCT to see if there's any evidence of thrombosis or dissection. You certainly see that there is some plaque building up here in the IVUS. And so if we had just used IVUS on the left, we would have realized, hey, there's definitely some plaque, which is consistent with the angiographic appearance. But in looking at the OCT, the luminal surface is intact. There's a guide wire artifact here. And then there's reasonable penetration through the first few hundred microns of the plaque, suggesting that if there is a fibroatheroma there, that it's a thick fibrous atheroma, as opposed to a thin cap one, with no real evidence of erosion or thrombus formation or dissection throughout here. So here we have more of a fibrous lesion up near the top. Over here we have a more bulky lipid-rich lesion that we can see that there's a large plaque volume on IVUS that we don't penetrate all the way through with OCT, but at least we can tell the first few hundred microns are not compromised and are fibrotic in nature. And so this was reassuring. And at this point, we decided this here might actually be a healed plaque, where you see that there's two layers here with some attenuation underneath that. We decided at this point that rather than commit her to dual antiplatelet therapy, that we would allow a more conservative approach so that she could have her bleeding issues resolved. And we treated her with medical therapy and clearly documented that, yes, she does have moderate atherosclerosis of multiple types, primarily fibrous and lipid-rich, and educated her on the importance of medical therapy, but did not proceed with an angioplasty at that time until the GI issues could be sorted. In this whole area of, I think, myocardial infarctions with no obstructive coronary disease, it probably represents on the order of about 10% of patients presenting with an ACS these days. So I think that that's an area that's an important one that's evolving in the literature with imaging, both intravascular imaging and non-invasive cardiac MRI imaging. This is another patient that is a patient who's only in her 30s. She's got a very strong family history of premature coronary disease. She had her first angioplasty at the age of 30 to her LAD in the setting of a non-STEMI. I personally treated her in about 2018 when she was in her late 30s with a stent to the right coronary artery. At the time, I only had access to single modality imaging, so I imaged with OCT and optimized that, and there was no disease proximal or distal to her RCA stent that I had placed. And then in the past few months, she presented once again with a non-STEMI. The LAD was patent. The RCA had a 50% lesion proximal to the stent I had placed in the RCA, but her culprit lesion for this particular presentation was clearly this circumflex that we can see here, which feeds long, but not necessarily easy to determine the size of this OM branch. It's a long branch that reaches far out towards the apex, probably is a larger vessel and is underfilled in this picture. So I wanted to use image guidance for this. And in light of the small diameter of the OM relative to the mid-circumflex, I primarily relied on OCT imaging for the distal portion and for IVUS imaging for the proximal portion. And it ended up being a larger vessel than originally anticipated. And so I placed two stents in the circumflex using the sizing information from the IVUS and the OCT, and then repeated the imaging afterwards to look for, in particular, an edge dissection distally here and for the integrity of the result that we had in the proximal portion. And so if we run through here, you can see again the IVUS on the left, the OCT on the right. We're starting in a relatively normal segment of that obtuse marginal. And as I come back a little bit, there's a small branch there seen on OCT, and then another branch, and a little bit of thickening, but there you can see that the stent is well expanded and that it shows the step down, but there's no trauma to the vessel. And as we come back further, you'll then see the overlapping segment. And you can see 2 layers of stent here and a little bit of under expansion. And so I went back in there afterwards and I did some further post-dilatation to that particular area, and then came back more proximally to where the vessel's larger. And she still has a fair bit of residual disease here. And you can tell that there's disease all throughout her circumflex. So there wasn't an ideal normal area to go to in the circumflex. And I chose a landing area based on the pre-PCI pictures that had at least a thick cap of fibrous tissue all around it, so that it would be less likely to dissect and be less biologically active. And so I wanted to choose an area that would be at lower risk for future acute events. And then as I go through here a little bit more, knowing that she's had multiple presentations with acute coronary syndrome, you can see that there's a fairly large plaque, eccentric plaque still here in the proximal circumflex. And then the shadowing here is consistent with some early atherosclerotic development, consistent with perhaps macrophages or a lipid-rich pool forming there, early lipid-rich pool forming there. And so, of note, I went back and just to talk about these patients with familial hyperlipidemia, I looked back at her OCT from 2018, and it truly was a beautiful proximal RCA with no disease in it whatsoever, with great stent expansion and lesion coverage. And it just goes to show how much I think we have to learn still about optimizing medical therapy, about how we can identify the pathology consistently, reduce a lot of the intra-observer variation, quantify this so that we can help patients like this who have had multiple presentations already at a young age, with multiple presentations with acute coronary syndrome. Thankfully, nothing that caused a lot of myocardial injury thus far, but certainly we have a lot to learn, and I'm hoping that a tool such as this will help us do that. So just to build a little bit further on some of the comments made by Drs. Prasad and Fall, I personally, in developing this technology, have learned a lot about the limitations of IVUS and OCT and about the practical nature of switching between the 2 modalities during a case. I'm excited to be able to be using it in my patients after working on its development with a lot of other talented people over the course of the past 10 years. And it's been a real joy to work with the physicians that are early adopters of this technology as we learn more about what are the limitations, how do we get rid of some of the artifacts that often act as a barrier to intravascular imaging. And when you have both modalities, does it help you at least get one image where you need to get a good image in order to make the next step in your intervention? And there's a significant amount of research that I think that this tool enables with respect to understanding treatment strategies, understanding vulnerable plaque and prognostic features that can come from intravascular imaging to help inform our patients as to what they should expect and what decisions they have to make in conjunction with the physicians that look after them. So this technology is now approved in Canada and Japan and has 510(k) clearance in the USA. We're anxiously awaiting approval in China in the near future. And we've done several hundred cases with a number of investigators in multiple jurisdictions around the world. A lot of complex pathology out there that our system has been used in. And so we're learning a lot as we move forward. And as mentioned earlier, making a lot of improvements for image quality, ease of use, and robustness. You want people to be confident using this technology, that it's going to perform the way it needs to, and that it's simple, and that they can focus on the patient as much as possible. And so we've been working hard on all of those aspects. And then we've had some fortunate to have a number of researchers help us start building a literature around this technology. His colleagues in Hamilton Health Sciences Center published our first-in-man study, which is available online through catheterization and cardiovascular interventions. Dr. Barantis, who's joined our call, he and Dr. Bajaj from Bart's NHS in the UK recently made a great presentation at TCT showing how artificial intelligence can be used for plaque characterization based on some autopsy specimens that we've been looking at. And we look forward to doing studies in the natural history of ACS, as well as multiple studies to look at all the different ways where imaging can be helpful, whether it's ISR, CTOs, thrombotic events, et cetera. And so I'm quite excited about where we've been able to get this technology to date. I'm very grateful to Drs. Fall and Prasad for their enthusiasm in being early adopters, as well as the other doctors at their center and at other centers, and really excited to move this forward. So thank you, everyone.
Thank you, Brian. We do have a question that did come in through the chat. I'll turn it over to Julie to ask. I know we're running a little bit late, but if we can maybe entertain at least one question at the end here, that would be great.
Yeah, so we got another question here. So there's a comment that identification of plaque erosion by OCT is not always an easy task. So the question is, detection of plaque erosion and differentiation from plaque rupture may be easier with combined imaging, and what does the panel think about that?
So that's an interesting question. I'll let Khady speak more to that. But in terms of plaque erosion versus plaque ruptures, I think you can see both on OCT versus IVUS, and it depends on your eye. Like anything, I think where this technology is most useful is if you are the best imager in the world, you may be able to see things with IVUS that other people can and things with OCT that other people can't. But the reality is, and someone that like me that I've been imaging now for 5 to 7 years, I struggle seeing plaque erosion and plaque rupture on IVUS the way I can see it on OCT. But Khady, who's been imaging longer than I have, may be able to value that. And so I absolutely agree that having both technologies will train your eye in both technologies, but it'll also allow you to detect that where your eye may have missed it. But Khady, I'll let you speak to that a little bit further.
Yes, plaque erosion is not easy. It's not easy to see. It's a difficult thing to see the difference between plaque erosion and plaque rupture. Number one, plaque rupture is way more common. For me, every time I see one, the first thing I'm looking for is the flap. If the flap is missing, usually it's an erosion. If I get like a small indentation, like not completely a cavity, but if there is no flap, usually it's plaque erosion. But it's way more frequent to see plaque rupture than plaque erosion. I don't know if that answers the questions.
Brian, do you have any additional perspective?
No, I mean, Dr. Vermani did a lot of the initial research in identifying plaque erosion versus plaque rupture, and she had the benefit of pathology to look at. Sometimes a thrombus might have entirely filled up a cavity, and therefore it might be hard to see sometimes the dissection flap. And erosion, maybe I'd have to look at this a little bit more, but a little bit less of a correlation with as much of a plaque volume, whereas plaque rupture is typically associated with a much larger volume lesion. So I think IVUS can be helpful from that perspective, because if you have thrombus on the surface of something that doesn't have a large volume associated with it, perhaps more associated with erosion. But we're just opening our eyes with this technology to these things now, so it's hard to be too certain about it.
Yeah, I agree, definitely.
So in closing, I want to thank all of our panelists. I want to thank everybody who attended and participated and prepared for this webinar. We should have flashed this at the beginning, but we'll do this now. There's important safety information you can visit on our website. If you're interested in the system, please email seymour@conavi.com, and we will from time to time post some information or some questions on various Twitter accounts, including the Conavi Medical Twitter account. Dr. Megha has a Twitter account. You can see my account and Brian's, and we'll get some interesting images up there for you to take a look at. Thank you very much for your time tonight, and we look forward to seeing you on another webinar.